Go ahead, Storm.
All right. Thank you all. Good morning for being here. My apologies. A few minutes late. I'd like to call a meeting of the Quality and Patient Safety Committee to order. Will the secretary please call roll?
Director Kim? Director Sorrell?
Present.
Director Stain? Is absent. Director Webster Cross?
Present.
Chair Bott?
Present.
Ms. Merriweather? And acting as a substitute member for Director Stain is Director Harrington.
Present.
You have a quorum.
Thank you. The next regular meeting of the committee is scheduled to be Friday, September 19th at 9 a.m. I'd like to entertain a motion to allow Directors Sorrell and Webster Cross to remotely participate in this meeting as voting members. So moved. Motion been made and seconded. Is there any discussion on the motion? All in favor say aye. Aye.
Aye.
All opposed? All right, motion carries.
And Chair Bott, also for the record, I apologize. Board Chair Garza is on remotely too.
Oh, terrific. Thank you. Glad to have Chairman Garza's with us today. The first item on today's agenda is public testimony. As a reminder, written testimony will not be read in the record, will be included in the official record of this meeting and posted to the website. Madam Secretary, do we have speakers who register to provide in-person or virtual oral testimony or submitted written testimony?
We did not receive any registrations to testify nor any written testimony.
Thank you. The next item on today's agenda are proposed Georgia Hospital Department Division Chair appointments, reappointments, which will be reviewed by Dr. Lawrence Smith, Chief Medical Officer.
Good morning, Chair Bott and Directors. Can you hear us?
I can hear you.
Okay, thank you. So this morning I have three to present for Division Chair for the medical staff of John H. Sturger Hospital of Cook County for a 2-year term. First would be Dr. James Turner for August 1st, 2025 through August 31st, 2027 to the Chair of Division of Neurosurgery under the Department of Surgery. Dr. Towner attended University of South Alabama Medical School. He did his residency at University of Rochester. He completed his fellowship at Royal Melbourne Hospital in Australia. And he first joined Cook County in July of 2021. And this, again, appointment starts August 1st, 2025. The next would be Dr. Teresa McCarthy for Chair of the Department of Physical Medicine and Rehabilitation. Dr. McCarthy attended Midwestern University for medical school, did her residency at Rush University. She has been with Cook County Health since January 1999. And this appointment would begin August 1st, 2025 for 2 years through August 31st, 2027. And last, I have Dr. Paul Malarkey for the Chair of Division of Mammography under the Department of Medicine. Dr. Malarkey attended Tulane University School of Medicine, did his residency training at University of Illinois here in Chicago, and did 2 fellowships at the Stanford University, one in musculoskeletal imaging, one in breast. He first joined Cook County in 2016.
Great. Thank you. I'd like to entertain a motion to approve item 3A, the 1 proposed Georgia Hospital Division Chair initial appointment, 1 proposed Georgia Hospital Department Chair reappointment, and 1 proposed Georgia Hospital Division Chair reappointment.
So moved.
Second.
Motion has been made and seconded. Is there any discussion on the motion? All in favor say aye.
Aye.
All opposed? Ayes have it, the motion carries. Dr. Tom Patronakos, President of Sturger Hospital Executive Medical Staff, followed by Dr. Paul Allegretti, President of the Provident Hospital Medical Executive Committee, will now provide any reports and present their medical staff action items for the committee's consideration and approval.
I do not see Dr. Patrianakos,
Remotely.
but the medical staff appointments were sent to you in advance and are presented for your consideration. I do see Dr. Allegretti, I believe, was remote.
Okay, great. Well, Dr. Allegretti, welcome your report.
Hi, good morning, everybody. I would like to present the credentials meeting that met for Provident that met on July 22nd and was approved at that time, and also approved by MedExec on August 5th. And I presented it to you for respectfully asking for approval. And I'm here if you have any questions or comments.
All right, questions from our directors? Note that under comments, the temps granted have been recorded as well. All right. I'd like to entertain a motion to approve item 3, or approve item 3B, the Sturger Hospital and Provident Hospital medical staff appointments, reappointments, and changes.
So moved.
Second.
Motion's been made and seconded. Is there any discussion on the motion? All in favor, say aye.
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 Opposed? Ayes have it. Motion carries. Thank you. The next item is the July 18th committee meeting minutes. These were approved at the July board meeting, but are being presented for any further edits or corrections if needed. Any corrections need to be made to the minutes for July 18th, 2025. Okay. I'd like to entertain a motion to accept item 3C, July 18, 2025 meeting minutes of the Quality and Patient Safety Committee.
So moved. Second.
Motion's been made and seconded. Any discussion on the motion? All in favor, say aye.
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 All opposed? Ayes have it, motion carries. Thank you so much. The next item is a review of the OpEx dashboard goals and tactics by Raji Thomas, Dr. Arnold Turner, and Craig Williams. So, Raji, good morning.
Good morning.
So nice to see you all this morning. We will start with the stronger one. If that's okay with you, Debbie? All right, can we go to the next slide? Next slide, please. All right. So Stroger dashboard, the first metric that we would be presenting would be the physician communications with physician domain. As you can see here, one thing I want to point out and congratulate the team on is around our accomplishment of 90%, over 90%, which is above our stretch goal for physician communication with the patient. And some of the tactics that the team worked on that has helped us improve our performance includes annual CI care physician training, along with rolling out teach back method, and the team hopes to accomplish that by the end of the year. Their goal is 100% of all our physicians receiving this training. They're also working with our physician groups to help them customize communication approaches based on patient preferences. We will move on. Well, we are also looking into publishing the work that they've been doing, because we are at the top decile for this specific metric when we look at national benchmarks. So this is something that we are very proud of. Congratulations to our physician partners who are working with Ling and team on patient experience.
Great work, congratulations. Thank you for sharing.
Yeah. Then the next metric under patient experience domain is related to communication with nursing. As you can see there, so the purple color, denotes that we've been performing above our stretch goal. As you can see, the performance has been holding steady for several months now. And some of the tactics that team had been working on includes rolling out compassion connected care under Dr. Witten's leadership. And they are also looking to increase the hourly rounding by leadership with the patients. The goal is to get to 40% by the end of the year. They're also implementing eye rounds on weekends with the goal to complete that, with the goal to get to 90% of rounding on weekends by the end of this year. As you can see, these tactics have really helped the team to move the needle on this metric that had been a little resistant for us for a long time. So kudos to that team as well. We will move on to the next domain, clinical outcomes. For mortality index, you see a lot of red there, but the positive news is that for the past few months, we've been seeing the performance really turning the corner for these metrics. And also the same goes for PSI 90 composite performance. Though we had a little blip in May, looking back at the performance of that metric for the past few months, it's been really holding really in the positive direction. We will bring this back, this team to the board. Sorry, we will bring the team to the board to talk about some of the tactics that have seemed to have helped us move the needle on this metric. As you know, we have discussed with the board in the past our clinical documentation improvement efforts in the past had, it took us a lot of effort, a lot of organization energy to, help us to get where we are now. So we are very proud of that that work that the team has been leading, and we will bring the team here to present to the board on some of their specific tactics. Moving on to sub 1 bundle compliance. As you can see there, the performance has improved over the last several months. However, I don't want to steal the thunder of the team that will be here to present to you all today on some of the specific tactics that they had deployed over the past several months. Moving on to readmissions, the first metric is on COPD readmissions rate, which seem to be doing very well. So Debbie, can we move on to the next slide, please? Thank you very much.
I think as a question on the PSI 90, for that 1.12, any understanding of what might have contributed to that?
It's related to the documentation opportunity that we have. We established an interdisciplinary team towards the end of fall, end of summer last year, which is helping us tremendously with improving our clinical documentation. But as you can understand, it has multiple facets to it, including educating our physicians on the accuracy of clinical documentation, making the clinical documentation easy for them to do. So this team had been working on developing, scripts for the physicians, some power chart options make that clinical documentation easy.
Yeah, I had a question as well, because when you look at the numbers and you see all this red here, you become concerned. But by the same token, if you're saying that this is related to coding, and that's a human error, it doesn't mean that things were actually as bad as they seem on paper. Is that correct?
Dr. Harrington, you are right. We have identified that as our biggest opportunity. It's not the quality of the care, it is the documentation of how we are performing that care. That has been, a challenge for us with improving our CMS scores and, the publicly reportable scores. So you are right. It is not just, it has multiple, elements to it, including physician understanding of what needs to be charted and, the time stamping of the documentation and identifying the correct ICD code. It's a big, big animal we are trying to tame here. But the team has started that work and it's starting to show some impact.
But the note is the quality of care has not been impacted. The quality of care is actually high.
Correct.
But the reporting has some problems. You need to correct the reporting.
Correct. That is exactly the point. When we review these cases real time, so close to real time, I should say, we are realizing that it's not that the care was not provided, but the biggest opportunity was around documenting that care appropriately. So with this interdisciplinary concurrent review, we've been able to look at each of these cases close to the real time. There are reviews happening every week, where, the team that includes physicians and, coders and billers who all come together and look at the missing elements. So the team has been identifying opportunities that we can work on real time. So, as I said, this was a metric that had been in the red for a very long time for CCH. And finally, we are starting to see things in the green, which is very encouraging.
Do we have data other than that, other than this, that indicates that the quality of care was good? Is there another source of data, because you say it's good, but is there other data to support the fact?
Perfect.
Or is it anecdotal?
Director Harrington, that's a very good point. When the subsys team presents to you, you would see, I hope you would see exactly the point we are making here, that it's not the care, it's often the timestamp that's missing. I think, sorry, folks, I'm going to steal your thunder. You know, with the substance work, one of the greatest opportunity we have is around antibiotic administration. When we do the chart review, what we are noticing is that it's not that the antibiotic wasn't administered, it was that the timestamp was delayed. The other opportunity is around lab collection of the specimen. But if you look at these patient charts, it would appear that labs were not drawn in a timely manner. However, when we do, you know, in-depth review of these charts, we realize that patients did receive all the care appropriately. However, the timestamp showed, you know, there was a delay. You know, again, I'm sorry, folks, but, you know, what we realized is that the timestamps between what was captured in Cerner versus what's captured on the lab are not matching up. So lab data would show that the labs were drawn correctly, appropriately, timely. However, you know, there is a time lag. You know, so there are lots of moving parts to this, and that's exactly what this team is working on.
I don't know if I understand this correctly, but that sort of thing happens in clinical setting when clinicians are just so busy. They do the work, but I'm just going to read documentation later, right?
That is one of the multiple factors that is leading to delay in documentation or missed documentation. That's why it's going to take a lot of effort as an organization to change that culture and help our physicians understand the need for documenting in real time.
Yeah. Director Harrington, go ahead.
When a prescription is given to the patient, I mean, do you have the barcoding? Do you have the barcoding?
So they do scan, yeah.
Okay, then that's pretty accurate.
Yeah.
I mean, if you're giving a patient an antibiotic, it should pick up right there.
So we have to match up various pieces to that one order, right? The ordering of the antibiotic to the timing of the administration, and if it involves lab, you know, for substance, you know, lab needs to be drawn to. So matching up the timeline and telling that story correctly. That's where we are realizing that there are missing pieces or delayed pieces that do not nicely fit in with the puzzle.
The prep director, I was saying, Raji, perhaps we can bring this conversation to the next meeting and have more of a discussion around some of the process that the directors may have questions about. I think that the work around high reliability that the team and the organization's been on will, I think, help some of this work, so we can maybe connect that piece to the conversation as well. Because I know we have a packed agenda, so I just want to make sure that we're able to get through.
We will invite the CDI team to come and present to you next month, so they can talk about their current process, some of the challenges that they already have tackled, and what, you know, the challenges ahead of them.
Yeah. Well, directors, thanks for the questions and input.
Absolutely. So for under readmissions, COPD readmission rate, we touched on that. Some of the tactics that the team is working on includes, increasing inpatient pulmonary rehab referrals, as well as increasing monthly smoking quit aid prescription. Moving down, under the same domain, we have another metric that is related to post-hospital appointment days. And the inpatient team, Stroger team, is working with ACHN group to increase the allocation ratio for our general medicine versus the generic ACHN appointment. Moving through the Stroger dashboard, the next domain is for throughput metrics. So the geometric length of stay, GMLOS, As you can see, we've been performing our baseline. And if you look at the monthly performance, that has been really, doing very well. For the past couple months, our performance have been about the stretch goal. This has really been a work that I think we have brought to the board in the past that involves changing our model of admission, which, as you can see here, definitely has helped us improve those numbers. Last metric on good, ED LOS, length of stay for ED discharged patients. We've been performing very well for the past several months, and some of the tactics we deployed are around utilizing nursing-driven triage protocols and identifying our opportunities for earlier initiation of care. And also, they have deployed a process that allows them to improve door-to-discharge time for low acuity patients. All right, next slide, please.
And then I think when we talk again about the previous component, can touch on also the COPD readmission rate, because that one is, spiked
Yeah.
this month, right? Unless there are any overarching questions that directors want to ask about. Okay.
Yes. Dr. Turner, are you on the line?
Dr. Turner?
Remotely.
Okay.
That's Roger. I'm on. Good morning.
Morning, Doctor.
Dr. Arnold, Chief Hospital Executive, Providence Hospital, Cook County. Good morning, Chair Bott and directors. Want to review the Providence OpEx Committee dashboard. The first metric is the return on survey volume. Thus far, in this, right now in the second quarter, we have 15 surveys returned, but this is always refreshing. The data is constantly being returned. As the data surveys continue to return, we hope to see our linear trend surpass our year prior, which was at baseline was at 19. So I think we'll be able. We've instituted some tactics to improve the return. We'll see that as the months roll by. The next metric is the communication with nursing domain. Our nursing staff under the leadership of our CNO Mike Moonen put a lot of effort in this. You can see that for the last 2 months, we have been better than previous years with the rolling 12 months. And if you look at the return on the monthly, that in April and May, we were both at goal, at target, and met the stretch target for May. We continue to work on this. I think we'll continue, be able to hope reach the target goal later on this year. Next one is the sepsis compliance bundle. This one we still need to do some work with, although the last 2 months for May and June, we were above the previous year, but we're still not quite hitting the target on that. We actually met yesterday, and we're going to ask the work group to review their tactics to see if there's anything we can do to make sure that we're moving toward the target, not just moving toward it, but actually achieving that target and possibly meet the stretch target. So more to report on that hopefully in the coming month. With respect to falls, this data hasn't changed since last month because of the timing of the meeting, but we don't have the July data just as yet. But for the year to date, we've had just 9 falls. The target for the year is 16. I think we will meet that with the tactics that we have put in place to achieve this goal. Moving on to the left without being seen, Dr. Allegretti, the chair of emergency medicine here at Provident, and Amy O'Malley, the nurse manager, continue to, and their staff continue to do well with this metric. You can see that for the past months, we have been at at target, and at for the rolling 12 months, and for the monthly, we've been at the stretch goal. So kudos to that team in the ED. I'm sorry, that was the ED to decision to ED, a mid decision to depart ED. Now the rolling 12 months was left without being seen. Again, we're doing quite well in ED with that. For the past 2 months, the rolling 12 months has been below the goal of 2%. And you see it with the monthly rate that is approaching the stretch goals, which have been 1% or better. Any questions?
Thank you. Dr. Turner, any questions from directors? Okay. Well, thank you. We'll go to Craig Williams, who's remote, for ACHN site review, unless, Raji, anything else you want to add on Providence?
I think it's fine for ACHN.
Okay.
So under the patient domain, patient experience domain, the first metric is on staff work together for you. As you can see, for the past couple months, we've been performing above our baseline, and we are getting closer to the target. And for provider communication that addressed patient concerns and worries, again, we are performing above our baseline. However, we are not there yet, where we can say we have accomplished our target. However, some of the tactics that ACHN team has implemented include identifying and training champion coaches that will support the teams in delivering, appropriate communication that is appropriate for the patient population that they are working with. They are also reintroducing and retraining all ACHN staff on compassion connected care. The goal is to complete that training. 75% of all staff completed, with that training by the end of this year. And as part of improving the metric performance for care provider explains problems and conditions, they are implementing a shared decision-making model with the goal to have at least 75% of all staff trained by the end of this fiscal year. As you can see, that metric had been performing very well. Again, as Dr. Turner mentioned, we are going through our mid-year review of the metrics and tactics, not the metrics, but the tactics, if the tactics are really helping to move the needle on these metrics. If not, the teams have been, asked to take a relook at the tactics to see if they need to pivot and identify other tactics that can help make these, the metrics perform better. Under HEDIS measures, the performance for breast cancer screening has been holding very steady. We've been performing above our stretch goals. For hypertension management, again, we have met our target for the past several months. The team is going to look at additional opportunities to get to their stretch goal shortly. Empowerment continues to perform above our baseline, but again, that's something the team has taken on recently. The team started out as a group that was focused on value-based care. They identified empowerment as an important element that will help them get
encourage people to get registered, but if they don't come in, the numbers are gonna be lower than we would like. So I don't know what we're doing, but it's not much more we can do. I guess that's what I'm saying. It is patient dependent to schedule these visitings going in, and I'm sure we're aggressive about doing that. But it's something we don't have real control over. The individual patient has more control than we do.
That's true. There are specific tactics that the team have identified that they think would help increase patient access. So they are increasing those access points for the patients on a daily basis. So the screening per site can be improved and increased. So it's basically, focusing on patient access. They are also working with clinic diets to, make sure they are following the updated guidelines. So, the scope of or the patient population that we should be including based on the new guidelines would be included in our screening. And the team is also working on a number of outreach tactics to increase, patient awareness of the need for screening.
And there may be an opportunity with mobile mammography to actually screen more people.
Yes.
Because what we're telling people is come to us and we'll do it, but mobile mammography is an opportunity to take it to people
Absolutely. Yep.
in the community.
We'll take that feedback. Yes.
Okay, any other questions? Thank you. Appreciate the progress and the good work.
Thank you. I want to give kudos to the team, our CDI team that will be presenting at BCN on some of the tactics that they've been working on, and we are very proud to bring them to the board next month.
Thank you.
Thank you.
The next item's update on sepsis-related activities that was requested at the last meeting, which will be reviewed by Dr. Joseph Palter, Dr. Sydney Hyden. Thank you so much for making time to be here.
Good morning. I'm Dr. Radigan. I'm the lead physician for clinical outcomes, and so I'm going to introduce our lead physicians for PSI 13 Sepsis Committee. First, we're going to have Joe Palter. He's one of our outstanding ED attendings, and then one of my wonderful colleagues, pulmonary and critical care, is Dr. Sydney Hyder. So they're going to be presenting together. Thank you.
Thank you.
Thank you. Good morning.
Good morning.
Good morning, everyone. Thank you for having us, and thank you to our sepsis team behind me to be with us here today. So Dr. Palter and I are very excited to talk to you guys about kind of the progress we made over the past 2 years. So I assumed the co-role with Dr. Palter in terms of leading sepsis around 2 years ago, after Dr. Radigan kind of moved on, and we've been able to make pretty big strides. So one of the biggest kind of changes that we've encountered is that we're now working with Q-centrics when we are abstracting and analyzing our sepsis cases. What that's impacted in the way we view sepsis is almost changing the way that we actually are defining the SEP1 bundle and determining the timing of compliance, which has changed the way we've approached a lot of our care and a lot of the processes that we're now implementing. And we've been very thankful for them because they've really illuminated a lot of the compliance, that we've been missing with CMS and trying to redefine that for us. So we have been working very closely. Oh, yes.
Yeah, you say you changed. What were you doing that you changed from? I don't know what you changed.
So we're going to get to that in the next few points. Yeah. And just to kind of take a step back, when we talk about the SEP1 bundle, without going into specifics, what I'll say is that there's very specific things that need to be met to have compliance to the bundle, and they're very time specific, whether it's 3 hours or 6 hours. So we are always kind of racing against the clock and trying to meet that compliance, and all of the processes that we put into place, which I'll get soon, to meet that compliance. So through Q-Centrics, we've been able to actually meet with a lot of our kind of partner hospitals that also have been facing issues with SEP1 compliance. They've been hospitals similar to the structure of ours, and we've been able to kind of share what we've been doing, learn from them, and get a lot of great ideas in terms of how we can improve, which has kind of molded a lot of the steps that we've been taking in the past 2 years. And then the third part, in terms of identifying our root causes of fallouts and improving our bundle compliance, is kind of the meat of the talk. So we work very closely with our amazing data analyst team, Jen Rozenich and Andrea Ramel, to kind of review our data monthly, and they are kind of our eyes and our ears in terms of where we can be making those improvements. So the first thing that has kind of been illuminated for us is issues with our documentation in our charts. So as I mentioned, step one, bundle compliance, is very time specific. It needs to be done within like a 3-hour or a 6-hour time period. And one of the things that we're finding, especially working with Qcentrics, is that the way that we time our notes or the way that things are being put into Cerner or the EMR is affecting that timestamp or that our compliance. So we've been working very closely with HIS to try to figure out how we can best timestamp or at least put time to the work that we're doing. Because to be honest, we are actually doing a very good job with sepsis. Our patients are doing well, care is being given, we're just not getting the credit for it. And if we're able to figure out that timestamp issue, our hope is that we will again be getting that credit for the care that we're giving.
So it's a data issue, not a patient-related issue. That's what you're saying.
Well, that's one aspect of it, yeah. Right. The second aspect of it is issues with blood culture collection and its documentation. So you may put in an order on the floor in the ED for blood cultures, and they could be collected by nurses, in a timely manner. But the way that that time is being represented in Cerner or the chart is very different from when the care is being given. So we have had fallouts due to that dissonance of the time compared of when blood cultures are being collected and when they're being processed, which is causing fallouts, or us falling out of that 3 to 6 hour period that we're trying to obtain. So we're working really hard, especially with our lab, to better understand how we can better document the care that we're given, because we are collecting those blood cultures. We're just not getting that credit for it being done within the 3-hour time period. The next kind of process that we implemented was automatic or reflexive labs. So collecting certain labs, if labs are high, is a part of that bundle compliance. So we worked again with HIS to just implement, if a lab is high, an order will automatically go in and prompt our nurses to collect it, which has been very helpful. That is something that existed in the emergency department previously, and now we're actually trying to, or we are implementing it on the floors, which was a big step for us. The third big step is creating a new sepsis power plan. So sepsis power plans aren't a new conception. They exist across hospitals. And we had one previously, but the sepsis power plan that we had was very cumbersome and difficult to use, especially for our ED providers that see almost 80% of our sepsis cases. So we worked very closely with HIS and a lot of our stakeholders to create a whole new sepsis power plan that is much more streamlined, focused, and easier to use. And it also provides for better documentation, which we're hoping we'll start to see the impact of in the upcoming weeks to months. We now have a new sepsis coordinator. We are extremely thankful for Raji Thomas getting us Becca Messina. Like, having that sepsis coordinator is going to be so impactful in the year to come. And we are so excited to see what she brings to the team already. She's been extremely helpful. And so that is honestly one of the biggest kind of moves that we've had in the past year or so for our team. The next process that we've implemented is looking into concurrent case reviews. And what this means is a lot of times when we're abstracting data, we're getting that data 3 months delayed. So you can imagine if you have a fallout from 3 months previously, if I want to fix that problem, it's already passed. The provider who gave that care may not even remember the case, and it's hard to really give lifetime feedback to them. So Andrea and Becca have been working also into looking, how do we get that data more quickly? How do we get the fallouts live time? And how can we actually intercept them before they become fallouts, or at least give feedback in a much more efficient manner? Which we think is probably one of the most impactful things that we can do, because if you can catch someone in their steps making that mistake or forgetting to place that lab, hopefully we can tell them within, 24 hours to a week, and they'll remember it and try to change it in their next steps. And then the last one is patient PI training for ED nursing leaders related to sepsis opportunities to improvement. So again, this has to do things like blood culture collection, trying to remember, getting repeat lactic acids, and our co-lead, James McCracken, who has been helping out a lot in the emergency department, has also been leading, meeting with nurses, discussing sepsis compliance, and trying to reinforce all the important steps that they need to do. There's another slide that I'd like to highlight, unless anyone has questions on this slide.
Any questions? Thanks. Go ahead.
Yeah.
Do you have any data on the mortality rate of sepsis patients? Those that got the perfect timing, those that didn't get the timing right. Do you have any information? Because outcomes is really important in sepsis.
We do have mortality data. It's certainly related to it, but with sepsis is a wide spectrum of that. And actually, our better performance tends to be with our sicker patients because they get identified earlier and then more resources. That doesn't necessarily correlate with better outcomes per se because they come in so much sicker to begin with. So it's we do have that data that we do follow, but it is complicated from the sense of one patient might come in much less sick than other patients, so it can be difficult to tie direct performance to mortality outcomes specifically.
But could you also, do you have an adjustment to look at the patients as they come in? Because I agree, sometimes people will sit at home for 2 days with sepsis, and then they're very, very sick. So do you have anything to assess where they're at in the stage of sepsis when they come in?
Certainly, we could divide it between septic shock or just severe sepsis and look at mortality data across that time. It's not something we prepared for this meeting specifically.
Oh, sure. And I think we have another comment. Can you use the mic?
You want to use the mic?
Thank you.
The question was mortality. If you look at in terms of principal diagnosis cases for the year of 2024, the most recent mortality was 6.16%. If you look at it though, in terms of if you look all cause, in terms of coding for sepsis, the mortality is 9.6%. And we also have the data, if you'd like me to tell you, in terms of the compliance for basically our Step 1 bundle. Would you like me to share that with you?
Sure.
Okay, so our Step 1 bundle compliance for, just so you know, like a couple of years ago, it was like 18%. Most recently, it's 69%. And if you look at our bundle compliance when patients, like what we're saying is when patients are super sick, we do an amazing job. We actually are far above average. So we're at basically for Step 1 septic shock 3-hour bundle, we're at 91%. And then for 6-hour bundle, we're at 100%. That far surpasses the national average at 71% and 85%. So we actually perform quite well. And a mortality of 6% is absolutely outstanding.
Yep. And we can, I think, outside of this meeting can provide additional follow-up. But thanks for that, sharing that high-level perspective.
Yeah, and I just wanted to highlight on the next slide our blood culture collection documentation. So as I mentioned, one of the, barriers we've noticed is issues with, again, getting the credit of collecting those blood cultures because they are being collected. And our nurses have been working very, passionately about trying to do a better job with their documentation. And you can see going back, I think that's December, when we started implementing the direct feedback from nursing and having their huddles, we start to see improvement in our blood culture documentation. So we are seeing those slight movements stepping forward. I think when we review the sepsis data overall in the past year or two, it may not be where we want to be, but I think we have really laid the groundwork of a lot of steps in terms of implementing new processes And we're starting to see the fruits of that labor. And our hope is that in the next, 6 months or so, we're going to start to even see improvement in those numbers.
I think the blood culture data really exemplifies like our sepsis journey recently because it's a change in understanding of what we needed to do. Namely that it wasn't enough just to order blood cultures, we had to document the collection time, recognizing we didn't have a mechanism to do that, building a mechanism to do it, educating our providers to doing, now using our data team to collect performance data on that, feed that back to our team, and then educate them. So you can kind of hear, this is one component of sepsis, not even the totality of it, but we identified this as something that we really needed to improve upon and brought in all these different facets of our team, the clinicians, data analytics, quality, nursing, physicians, to really collaborate and figure out what we needed to do in order to improve this process. And we hope that we can kind of piecemeal by piecemeal figure out where our high yield interventions are and utilize all these resources we've now been provided to improve our performance. And this slide, I think, shows that we're starting to get some results, and we want that to translate even more to our overall bundle compliance in the future.
Thank you. Are there any questions for those participating remotely? Okay. We have, we'll come back to Director Harrington. Someone online want to ask a question?
I was just going to say, I'm really excited about the added sepsis protocol enhancements. That was a concern that I had regarding seeing those numbers. So I'm so glad to see that the additional, hopefully the sepsis enhancements will show some improvements going forward.
Yeah, the original sepsis.
Functional, but just not spread out where it needs to be.
Law got passed.
Or are there elements missing?
No
I
changes
was
to
just
it.
trying to figure out whether there were,
This was
somebody's like, well, what's not done, I guess that's what I was
Okay,
saying.
so what
much more friendly and focused on the performance metrics we wanted to improve upon.
Thank you. Yep. Echo that sentiment from Director Searle. Director Harrington.
No, I don't have a question, it's an observation. I just want to make a point. Years ago, I heard this phrase, the magic is in the minutia. And so we're talking about quality and quality improvement. The only way you can improve a process is to take a hard look at it, figure out how to do it better and move forward. So consistently what we're talking about is quality improvement. You have to take a hard look at what you're doing, make a change, and that change can make a major difference. And this graph that you presented shows that you're making a difference moving forward. So I applaud you for the work.
Yep. Well said. It's the plan, do, study, act cycle in motion. So appreciate the hard work and efforts to address this important issue and make progress. So thank you for sharing it. Any other comments or questions?
If I could, I just want to say thank you to the team. A lot of moving parts, as I know you all are aware. Thank you for coming to present today. Thank you for your hard work and your dedication on all of this. You're really moving the needle. It's deeply appreciated. Thank you.
Thank you. It's
And
really.
I think it should be showcased to others because your mortality rates for sepsis are very good. Thank you.
Yeah, I was gonna, thank you, Pat. I was gonna say that there's an opportunity probably here as we're doing this work on improvement to tell the story, which I know that the team is very keen on doing. So anything we can do to support and help, let us know. But thanks for the hard work of the team. Give our appreciation. And then the other thing we can talk about, I think Raji, with the high reliability connection. So these folks are also being trained, at the staff level that are part of this team. So I think that's part of this story too.
Right. Good morning.
Good morning.
Good morning.
Lynn Dang, I'm the Chief Experience Officer. So I'm going to share today the grievance and patient experience report. Just as a reminder, starting fall of 2025, CMS will require all hospitals to report the grievance resolution performance to their governing board, and this is why we're presenting it on a quarterly basis. So last quarter, I presented the fiscal year quarter one, which was from December to February. Today, we are going to report out the fiscal year Q2, which is March until March, April, May. Yep, March until May. Okay, so all reported cases. When we say all, this includes the grievances, the complaints, and the compliments. So as you can see, our numbers are pretty much consistent at 155 for the month, or 154. Next slide. And please stop me if I'm going too fast, because I know that we're at a time constraint. Yes.
No, we have time.
We have time?
Yeah,
Okay, yes.
Yeah. It's about 154 consistently out of what number? I mean, that's the numerator, what's the denominator?
So.
What people are we talking about? And are they duplicates?
Are they duplicates? Is that what you're saying?
Yeah, I mean, two questions. I mean, how many people are we talking about out of it's 155 out of what number, and how many duplicates do you have? So we know what the actual number of complaints.
So these aren't duplicates, they're
Individual.
they're new cases, but they're including the grievances, the complaints, and the compliments or concerns.
Oh, okay.
So I don't
So the
have, I
compliments
can
and
put the
100.
compliments also in here.
Okay.
Yeah, and
That's good to
concerns.
know.
Yes, and also just, I will explain the difference. The grievances are the ones where the patient did not get their issues resolved within the same day or within the time frame that they're in the hospital. And then complaints is when they have an issue and we resolved it right away. And then there's concerns, like parking. They lost their ticket, and now we're going to help them, get a discount or whatnot for their parking ticket. So that's concerns. Yeah. Okay, next slide. Okay, so here are the reports of the categories, and now you can see the various cases for complaints, compliments, concerns, and grievances. Also, you can see the trending is grievances are steadily declining. And I give kudos to our staff members because they are providing real-time services to the patients. That way it doesn't have to come to patient relations. So they're able to resolve the complaints right there on the unit. Next slide. Did we skip the report for the broken down by facility a month? Yeah, so this is just to share with you, Stroger gets the majority of the complaints and grievances only because we have a larger patient volume for Stroger. Next slide.
You have 4 levels
Yeah.
of complaint, and that's a bar grant. Could you indicate in the bar grant where each of these fall?
I'm sorry, what was the question?
You have a bar graph on all reported cases, and it consists of 4 categories: complaint, compliment, concerns, and grievance.
Yeah.
And so you could demonstrate in the bar chart how many complaints, compliments, concerns, and grievances we had. That's
Okay.
another way to.
Another way to see it, yeah.
Yeah.
Yeah, because
That'd be interesting.
So
I
I'll
think
add
the director,
that.
yeah, that would be
Okay,
helpful to
add
see
that.
what proportion
Yeah.
of the, is related to each of those 4.
Okay, great, thank you so much. So next slide. This is the top most frequently reported. Accommodation and access is still first.
Can you
That's
talk
up-
a little, can you just refresh on what accommodations access?
When they're calling, if a patient calls and tries to schedule an appointment with our system, sometimes they feel like they have the runaround, or if they're trying to get a referral with a doctor and they're just having a really hard time getting that referral. So that's accommodation and access, the majority of it. Just being able to schedule an appointment or being able to come in and get the service that they want on the same day that they want. And then just so you know, recently we've launched our volunteer resources program in February. And we're planning on using the volunteers to help us utilize AI. Right now, we currently have Narrative DX through Press Ganey to glean through all the comments and figure out what the pain points are, so that we could tackle those. But then, you know, everyone knows ChatGPT. We would ask our volunteers to help us analyze what our competitors are doing that's well, and also helping us to figure out the pain points on Yelp and Google reviews so that we could tackle that as well. Again, parking is always, you know, top, but as stated, that's more of a concern where the patient would lose their parking ticket, and patient relations spends a bulk of our time helping them with the either waiving the parking ticket or giving them a discount. Safety, very happy to say that thank you to Raji and her team doing the RCAs. It has dropped by 42% since the previous quarter. You know, previous quarter we had 12, and for this quarter we only had 5. Okay, and then next slide, please. Top 5 most frequently grievance reports. Behavior and respect, that is still a pain point that we're tackling. We're still providing training. Now we're adding coaching. We're doing more rounds on the units with the RN leaders and also our patient experience director to make sure that we emphasize on the culture of empathy and patient-centered care. Excuse me. The encouraging thing is for property and personal items, that has dropped as well for this quarter. One of the other thing is we just implemented using the Press Ganey iRound real-time service recovery for EVS and food services. We've dug deeper during our leadership rounding and found that those are the 2 pain points for when a patient has a complaint. So now we're able to put in the request for housekeeping to come and clean the bathrooms or whatnot, and we get it resolved right away. So far, it's been successful for the last 7 days. Next slide, please.
Yes. Could I just ask about the quality of care? Has that gone up or down?
The quality of care, that actually has gone up about 2 cases. Yeah.
And those are the ones unresolved in a day, the grievance?
Yes, unresolved within a day, correct. If you like, I could also dig deeper about those extra 2 for you.
Or just, no, I mean, I just wanted to know if this was increasing or decreasing.
Yeah, I could dig deeper too, because if there's a trend of increasing, then we really need to address it. Next slide. Time to resolution, and you know, we're very proud of the fact that 100% we are compliant by 100% when it comes to CMS requirement of sending out an acknowledgement letter within 7 days. And then here you can see that we resolved the grievances within 10 days or less, and then 20 days or less, and then 30 days or less. CMS wants us to resolve grievances within 30 days by 80% of our cases, and we are actually over 90% compliance. Just to share, you know, in March, we were at 96% compliance. April, we were at 98% compliance. And in May, we were at 92% compliance. The ones that took longer than 30 days, most of the time it's because we had to do extra investigation and either the doctor or nurses were on sick leave or on vacation, and so it took a little bit longer to close those cases. Next slide.
You can go ahead. They do have it printed in front of them. We're
Oh,
having some
okay.
connection issues.
Okay, I don't have to say next slide. Okay, thank you. Patient experience, very proud to see that the trending is upward. And then also, just an FYI, currently, right now, our target goal is 73%, but we are above it. And next slide, for rate the hospital, this is also trending upwards. As of today, for the number that we have for July, it's 74%. And we're doing pretty well at that, which is our stretch goal. And then also, I wanted to share, and I want to give kudos to our communication and marketing team, because besides our frontline staff working really hard, I believe that marketing and communication play a huge part in the branding, right? Because if we tell our patients that we're here to provide excellent service and help them understand that that's what our goal is, it really does help shift the patient's mindset of Cook County. And so so the communication and marketing team have been pushing out initiatives to remind the patients that we're here for them, and also to take the surveys.
The last three slides are all trending in the positive. That's very good news. And as a result, at some point you may have to reconsider your stretch goal, because you're almost at your stretch goal.
Yeah.
If you keep trending this, you'll surpass your stretch goal. So.
Yeah, we will definitely move. We'll move the target up as we meet them. Yeah.
Congratulations.
But so Cook County and the team are working very hard. We want to make sure to please our leaders and the board members, and so kudos to the whole team. All right. Thank you. I also wanted to share that for the doctor's domain on slide 12, I want to give kudos to Dr. Philip Alanis, who is the lead for the OPEX team. He has been on track with the training of the doctors concerning active listening, conducting scenario-based training to help staff recognize and adjust to different communication styles, as well as teach-back method. Our Dr. Dan McCormick also, we're going to start working on the training to simplify it. And the three focus is, kindness, communication, and not compassion, courtesy, right? Yeah, so we're just gonna try to because we're asking so much of our staff members, we wanna make it simple. And so we're gonna start creating a training on just those three topics as well. Next slide, please. Oh, I'm sorry. So nursing communication also upward. They have been working extremely hard, making sure to do roundings, making sure to do purposeful rounding. So kudos to Stroja and Provident team for leading with excellence and building trust with our patients. And here is the breakdown of the three components that would be under the nursing domain. And then what's new for patient experience and employee engagement? So we're at slide 16. We have the staff art exhibit that we're going to roll out fairly soon. I'm just waiting for legal to provide the final consent form for us to use their contact, to use their image and their names and the title for social media. But these are just examples of some of the artworks that were done by our staff members or their children. I love the shoe on the bottom. that is, one of our HIS managers' daughters work, and she's like 9 years old. Just like, yeah, we have so many amazing, talented people here, and we wanted to showcase that. So the next one is the Cheers for Peers recognition, Sharon Barnes. I think we've mentioned it last time, but this is what the signage looks like. We're so excited to be able to recognize our staff members. The way that this works is the employees will vote for their colleagues. So the leadership has nothing to do with it, right? And so this is encouraging them to uplift each other. Next slide, we have 2 community mural projects this time. One is at Bronzeville. The artist is Amanda Stout. We had 2 focus group meetings, and this we asked the staff members, the leaders within that facility, as to what it is they wanted, and this is the concept that was decided. Next slide, please. So this one is for the Juvenile Temporary Detention Center. Ahmad Lee is, we had about 3 focus groups with this one, and we wanted to be able to represent all the great leaders. And so we have, you know, Obama, we have like female representatives. We actually have a more updated version because we added some Asians and Caucasians as well, because we just didn't want to like stereotype and say it's only, you know, the Black Americans that would be in that facility. We want to represent all the diverse nationality. This is my last page, but I also wanted to share that on September 8th, we are hosting a Chief Experience Officer one-day patient experience summit for people for the CXOs across the nation here at Cook County. So that's something that we're proud of. They want to come and see our best practices, and so we can showcase all the great things we're doing. And then also we had our first patient experience retreat to help push our engagement survey results. We're meeting monthly with the leaders to go over 3 action plans to help move along the scores. Culture of safety will have, our next survey is January of 2026. And then the employee engagement survey will be June 2026. And that's all I have. Do we have any questions?
Outstanding work.
Thank you. Thank you.
Thank you. Appreciate all the hard work by the team. All right. Next item is regulatory updates reviewed by Joseph Capena, Director of Quality Regulatory.
Morning, everyone.
Good morning.
Good morning.
I've had a busy summer with regulatory. I'm gonna just give everybody an update. So, Joint Commission Healthcare Equity. This was a system certification over 2 days. Stroger and Providence, June 10th and 11th. We had no evidence of standards compliance or deficiencies, and we did receive a report and award letter back on June 14th, and it's a 2-year certification. That's great news. New certification for us. We also had more recently ACS bariatric certification. This is a 1-day at Stroger on July 11th. We had no deficiencies cited again, and we're still waiting to receive our final report that should be in just the next couple of weeks. We also had the National Commission on Correctional Healthcare, which is at CIRMAC. It's for the opioid treatment program over 2 days and was June 24th and 25th. We did receive some tentative findings on July 29th, but we're waiting on the official accreditation decision report. We expect that sometime middle of this month to early September, and then we'll update on that. Next slide, please. Also, just for the group, we had back on April 15th, I updated Providence application for the addition to the Bronzeville location. And at the time, I was alerted that the transition of what's called the substance use disorders, or SUD, would require an extension survey. So we were prepping for that. And then more recently, on July 14th, our account exec alerted me that their leadership team has reviewed it again and decided that Bronzeville Clinic will not be required a survey at this time. So we expect that to happen during the Provident Triennial survey. So just good news, gives us more time to prep. But again, that was an interesting update. Next slide. And I just kind of want to run down some of the upcoming surveys. Two of them that we expect at any time. The first one is IDPH outpatient dialysis here at Stroger. Again, expected any time. We've been waiting for them since back in December, so that could happen, you know, again, in the near future, hopefully. IDPH dialysis at Provident also expected any time. Coming up next week, next Tuesday and Wednesday, August 12th and 13th, is the American College of Surgeons Trauma Center certification. Today, I just want to state that this is a virtual survey, so it's documentation intensive. There will be a hospital tour, which again will be on Workstation on Wheels, and we've got that. We've been preparing for that for quite some time, and looking forward to that next week. We have what's called the Utilization Review Accreditation Commission, or URAC. It's Stroger. This is pharmacy related. We expect that sometime in August. So again, this month, busy month. We also have Illinois Department of Public Health EMS Resource Hospital Site Survey at Stroger. We expect that in late fall to early spring of 2026. We have, again, I guess a little bit before that, what's called the College of American Pathologists, or CAP, which is a lab accreditation. This will take place at Provident. We have a window of September 18th through December 15th. We are prepping on that, and I will tell you that they do, it's a semi-unannounced. They will give us a 2-week notification, so we'll know 2 weeks in advance of the date once that is posted or alerted to. And lastly, the National Commission on Correctional Health. This is for mental health accreditation at CIRMAC, and we will be submitting an application for this in late 2025 with the goal of having a 2026 survey. So a lot going on, a lot that's happened, and a lot coming up. Can I answer any questions?
Just a comment on, congratulations on the, going through the equity certification. And any comments or questions from directors or here or remotely?
I'll just share that Joseph is being modest about the no findings. The surveyor had surveyed for 14 years, I think she said.
Yeah, I
and
think that's
never
right.
had a survey with no findings. So
Wow.
Congratulations.
That's great.
the team.
Team did a really nice job.
Terrific. Thank you for adding that to Titus.
Thank you.
Thank you. Any other comments, questions from directors? No? Okay. Committee will not be going into closed session today, so we can move to adjournment of the meeting. Thank you, everyone. Meeting is adjourned.
Executive session. Yeah.
Not official.